Dr. SWATI PHULJHELE. I'm an additional professor at Dr. Rajendra Prasad Center for Ophthalmic Sciences, and I'm the chief instructor for this case. Along with me, we have our eminent speakers, co-instructors, Professor Rohit Saxena, who is professor, needs no introduction as far as neuro-ophthalmology goes on. And I also have so in the previous session, you saw Dr. Jyoti Matalia speaking about idiopathic intracranial hypertension in children. And I would be talking about the same thing in adults. There is some overlap, but most of the time the adult idiopathic intracranial hypertension is different from what we see in pediatric age group. So IH is a condition that is characterized by elevated intracranial pressure. And due to increase in global prevalence of obesity, there is increase in incidence of IH as well. And it has been shown that the moderate weight gain of around 55 to 15% is associated with greater risk of IH and in obese patients as compared to non-obese patients. Apart from weight gain, there can be secondary causes of IH like hormonal disbalance, hypervitaminosis, PCODs. Yeah. The clinical features include headache is the most prominent symptoms, which may be diffused and may be so worse that it may wake the patient at night and becomes even more worse in the morning. It increases with head movement, coughing or straining, and is associated with vomiting and nausea with or without photophobia. Diplopia may be another complaint because of the abducens nerve palsy. There may be presence of pulsatile tinnitus. What is much more prominent symptom of IH is vision loss. It's a prominent morbidity also. And it is usually reversible if treated timely. 40% of cases will show vision loss sooner or later at some point of time, and 10% of these patients may actually land up in bilateral blindness. So IH diagnosis still remains the clinical diagnosis of exclusion, but there are certain criteria into which the patient has to fit before we diagnose the IH. Essentially, these criteria include that all other neurological features should be not there in presence of papilledema, and only neurological feature that may be present will be a bilateral sixth nerve palsy. MRI may show certain subtle signs, and it can be confirmed with the increased CSF pressure, which should be more than 250 mm of mercury to 250 centimeter of water of water to label it as increased intracranial pressure. The papilledema IH can be diagnosed without papilledema also if all these signs and symptoms are there in presence of sixth nerve palsy and certain MRI signs. So what are the MRI signs? Why is MRI mandatory? So MRI should be done to rule out intracranial space occupying lesion. That's the first and the foremost indication. Then there are subtle signs in form of distension of perioptic subarachnoid space, partially empty stela, flattening of posterior sclera, and tortuosity and elongation of orbital part of optic nerve. MRI should be done whenever indicated to rule out cortical venous thrombosis. You can also do visual field analysis, which will show enlargement of blind spot or generalized peripheral suppression in cases of IH. The role of OCT is increasing day by day in neuro-ophthalmological conditions, and I think Dr. Smita would be talking about it later in this session. But in IH, it has multiple roles. One, it is used to differentiate papilledema from pseudo-papilledema, particularly drusen. You can see the configuration of retinal layers. You can measure the thickness of peripapillary RNFL and GCL layers. Then it also helps in seeing the effect of the treatment, whether the edema is coming down over the period of time or not. Also helps in determining the cause of loss of vision. Thinning of GCL is suggestive of optic atrophy. There may be macular changes which, in spite of best treatment, may not cause improvement of vision. There may be choroidal folds which may again cause poor vision. So this diagram or these figures are just to show that how at presentation there was marked RNFL edema, which over the time has come down with the treatment, and at 6 months became as good as normal. But what normal RNFL may give you a good, a relief, but it is not a good sign always. So many of these patients who have normal RNFL will show thinning of GCL IPL layers suggestive of optic atrophy, which is eventually setting in these cases. So just monitoring RNFL may not be enough in this patient. You may also have to monitor GCL to look into whether the optic atrophy is setting in or not. So it has been, in our study, we have seen that the baseline GCL IPL thickness has a good correlation with the final visual acuity, and thus it's a better monitor. How do you manage a case of IH? So there are two main targets whenever you are managing a case of IH. One is vision and another one is headache. So you have to deal, because these are the two most debilitating symptoms of IH. So first one is to removal of the cause, whatever the cause is, whether it's a hormonal imbalance or if there is an ICSOL or some secondary cause. So you have to deal with this cause. So you may need an endocrinology support, you may need a neurology support. Second most important intervention is weight loss, medical management, and then in the last, surgical management. So weight loss, as I was emphasizing earlier also, so weight loss, if is done with the range of 6 to 15%, may lead to early resolution of papilledema as compared to patients who do not have weight counseling and weight loss. So the impact of weight loss we have seen in our study was that the change in weight loss was very well correlated with the change in the grade of papilledema, with the change in visual acuity, improvement in visual acuity, and improvement in mean deviation on the visual field. Coming to the medical management, so one is acetazolamide, and it's a very commonly used drug. Everybody uses it. And the international idiopathic treatment trial now has given us an evidence that acetazolamide, if given in proper doses, can lead to significant improvement in papilledema and visual acuity. Then the other commonly used drug nowadays is topiramate, which is basically a carbonic anhydrase inhibitor and also helps in suppressing appetite, thus indirectly helping in weight loss. It also causes headache management, and it's given in doses of 25 to 50 milligram BD. Then you have surgical management, which is done only in refractive cases where the patient is not responding to maximal medical therapy. Surgical management can be done in form of either CSF diversion, optic nerve sheath decompression, or venous sinus stenting. As an ophthalmologist, our most common modality, most common surgical management is ONSF sheath decompression. And this is the video showing the same. So just like with any squint surgery, a limbal conjunctival incision is made, MR is hooked, MR is secured, isolated. Box sutures are passed through sclera to retract the globe. Then it's important to identify the optic nerve, which can be identified by the presence of vessels which are there. And once you have identified an optic nerve, a nick is given, and you can see the gush of fluid coming out of the nerve sheath. So it's just not enough to give the nick. You have to cut a window also there and see that it's good enough to be maintained. You close it as like with any other squint surgery. And to conclude, as I said, that clinical features and papilledema are the diagnostic sign for IIH. MRI and MRV are needed to rule out ICSOL CVT. LP should be done to confirm the diagnosis, and it's important to rule out the secondary causes. The management includes management of the vision and management of the headache. So maximum medical management should be tried before one can do a surgical intervention.